This afternoon, I am pleased to introduce you to Mr. Bill Stevens. Bill is a retired mechanical professional engineer who experienced a stroke in October 2013. He has participated as a member of our Central South Stroke Patient and Family Advisory Council for the past 5 years. He lives in Waterloo, Ontario. Bill has graciously agreed to share his story and his ongoing recovery journey to open our session this afternoon. Bill?
Hello, my name is Bill Stevens. I experienced a stroke on October 23rd, 2013. I was 66 years old, relatively healthy and physically active. I had a hemorrhagic stroke while playing hockey. My condition was immediately recognized as a stroke by one of my teammates, and I was quickly taken to hospital. I experienced no loss of consciousness nor pain of any sort. The effects of the stroke were total right side paralysis, total loss of speaking ability, some right facial paralysis, some difficulty swallowing, and some cognitive impairment. Critical acute care in hospital for 8 days followed immediately. The brain bleed that caused the stroke ceased in about 2 days. Inpatient rehab care followed for 57 days in hospital, working with speech therapists, physical therapists, and occupational therapists. My cognitive impairment lessened to the point of being nearly non-existent. Outpatient rehab followed for almost a year, and I continued to recover. After discharge from outpatients, I continued my community recovery by participating in YMCA programs, which took over seamlessly after discharge from formal care programs. After 9.5 years, I have regained the ability to speak with some limitations. I have limited walking mobility, and I lack fine motor control in my right arm. My facial paralysis is almost gone, and there is no apparent cognitive impairment, although some of my friends would disagree with that statement. My stroke happened quickly and without any kind of warning. When it happened, I had no pain, just fear, alarm, and confusion. I never lost consciousness. I didn't know much about strokes and thought that it would be about 5 or 6 months until I would be back to normal. I hadn't yet come to the realization that life would never be the same, that there wouldn't ever be a normal as I knew it. That realization would come slowly over the following months. I was hopeful for a complete recovery. During inpatient and outpatient care, I started to see evidence of improvement. I felt thankfulness for that and was very appreciative of the therapist's skills as they guided my recovery. At the same time, I was frustrated over the slow pace of improvement. Especially in the early days, I was very disappointed in my ability to. I didn't know then how much effort my brain was expending trying to recover. When the formal phase of treatment ended, it was replaced by a new program at the YMCA, created for people with mobility challenges, including stroke persons. I found the program suited my needs, so I didn't investigate other options. I am still participating in the Y programs. The benefits of these programs are not only physical, there are emotional and mental health benefits as well. Immediately following my stroke, I felt fear, alarm, confusion, not knowing what was happening. As I interacted with medical staff, therapists, and other patients, I became aware that I was much more emotional than before my stroke. My level of frustration at my condition and impairments quickly surfaced. I would cry uncontrollably for next to no logical reason. Despite that, I continued to receive excellent support from family, friends, and professionals. I came to accept my situation as I learned more about stroke and its effects. For me, one of the most impactful effects of the pandemic was the closing of the YMCA, where I had several years of established exercise regime activities, as well as the social support of stroke people like myself. Fortunately, the Y started offering virtual joint Zoom exercise sessions to replace the in-person program. Still, the pandemic created social isolation. The virtual program wasn't quite the same, resulting in some disappointment and frustration. Complicating the issue, my wife, Edie, was diagnosed with incurable cancer in October 2020. As her condition deteriorated over the course of the next 14 months until her passing, my focus shifted directly to her. I was her primary caregiver, concerned about the possibility of bringing COVID home to someone who had a compromised immune system. My focus was her well-being, not my own emotions. Throughout her illness, I was not allowed to accompany her to medical treatment until close to the end. That was very stressful for both of us, but I had to keep my emotions in check. Stress continued to intensify during her final days. My family and friends rallied around to offer incredible support. Then came Edie's passing, funeral, and necessary follow-up actions. All of that posed a different kind of stress. Edie had expressed concern about perceived lack of physical and emotional support that she anticipated for me when she would be gone. As painful as that was to consider and talk about, we had jointly put in place some mechanisms that would allow me to continue to live alone and to manage the premises. That had the effect of reducing stress on my family and on me. Today, the pressure and isolation caused by the pandemic has been eliminated or assimilated into my life. There was a huge void in my life after Edie's passing. We had been married for 54 years. Once the pressure of the situation was relieved, I felt empty. I experienced much sadness and loneliness. My family had to get back to their own lives. Being a very social person, I started to reach out to friends to reestablish personal connections lost over the 3 years of the pandemic and Edie's illness and passing. A great many people responded. I was invited to get together more frequently with my family, kind couple friends, and single friends, both male and female. One such person was a longtime widow friend. We started communicating regularly, finding that we had a lot of shared interests. We have developed a firm friendship that is now much more of a commitment. We still live separately, alone, but spend much time together. She has become a very important part of my life. During the past 3 years, my emotional responses have been through a whole range, from despair, seemingly endless stress, emptiness, and depression, to hopefulness and satisfaction, in my expanding social contacts. It has been almost 9.5 years since my stroke. Much of the intervening time has been tumultuous. I now fully accept my situation. I try to focus on what I can do rather than what I can't do. The fact that I thrive is a very positive thing in my life. I realize that my physical condition leads to frustration often in my daily life. To counter this, I tried to be well rested to better cope and allow myself as much time as I need to accomplish even simple tasks. Nutrition is important. Paying attention to a healthy diet results in better physical condition and the mental satisfaction of feeling good. Edie had been trained in nutrition and imparted some of that knowledge to me. With the support of family, friends, and special people in my life, including staff at the Y, I feel upbeat most of the time. My involvement in many volunteer activities, including a stroke patient and family advisory council, keep me busy in a very positive way. My contribution to the success of the stroke journey map was rewarding. The collaborative effort by all the council members was inspiring. I feel relaxed at home, having contracts in place to take care of work that I cannot do. I look forward to, with anticipation, to my social outings and volunteer work. They create a balance of together and alone time, which leaves me satisfied. Awareness and acceptance of my limitation is vital. I have recently been reminded that improvements in my condition are still happening. I had lost the ability to sing as a result of my stroke. I recently was surprised to discover that I could sing once again, although it's not as good as it was. While it is a very positive lesson, I won't be taking my tense at singing outside of my shower anytime soon. In general, my life post-stroke is enjoyable. Challenges will always be here. I have to recognize that and accept it. The journey to this point has not been easy. I've had to persist and sometimes push myself, but with the support of family, friends, and others, I feel on balance. I have adapted well. Thank you.
Thank you, Bill. And thank you so much for sharing your journey and opening us and reminding us all of why we're here. Thank you. I'd also like to now move forward and introduce Caitlin Reinhardt. Caitlin is a communication disorders assistant with the Waterloo Wellington Regional Aphasia Program, or better known as RAP. She's been with the program since its inception in 2013, and Caitlin has kindly agreed to do keywording for us during our various Q&A sessions throughout the afternoon. Thank you, Caitlin, for offering your support and assistance. I'd now like to move forward and introduce our keynote presenter, Dr. Abraham Snaderman. Dr. Snaderman is an assistant professor in both the Department of Psychiatry and the Department of Medicine at the University of Toronto. He is the founding director of the Neuropsychiatry Clinic at the University Health Network, Toronto Rehabilitation Institute, Brain and Spinal Cord Program, where he has worked for the past 27 years. He has been involved in the field of physical and neurologic trauma for many years. As a clinician teacher, he has been involved in training medical students, residents, fellows, and ancillary health professionals, as well as the general public for over 25 years. He is a member of the exam board and an examiner in psychiatry for the Royal College of Physicians and Surgeons of Canada, and winner of the Ivan Silver Award for Excellence in Mental Health Education, awarded by the University of Toronto. He is the vice chair of the board of directors of Community Head Injury Services and a member of several advisory boards for acquired brain injury organizations, initiatives, and programs. We are so pleased to have him with us today, presenting on After the Storm, Neuropsychiatric Issues After Stroke. Please join me in welcoming Dr. Snaderman.
Thank you for that kind introduction. And Mr. Stevens, thank you for that very inspiring story. I can't imagine what you went through, but I'm so glad to see how well you're doing. I'm going to now share my screen, and hopefully we won't have many issues. Let me just do this. Okay, I hope that you can see the screen. If anybody has any problems, just speak up and we'll try to correct whatever the problem is. I wanted to name my presentation After the Storm, and I found this beautiful picture in which on the right side you see the storm and then beautiful clouds clearing and moving, and then bright blue sky. And it's not unheard of for patients to refer to going through the stroke and recovering from it as exactly that, a storm and then the calm afterwards. So After the Storm is a title, and the topic would be neuropsychological issues after stroke. As is always the case, I have to disclose whether I have any conflict of interest. I do not have any conflict of interest. I'm no affiliation with any industry, whether it's pharmaceutical or medical of any kind. I am a clinician teacher, which means that I do not involve myself in research primarily. Hence, no research was harmed in the making of this presentation. The audience on this particular presentation is quite varied, so I will try to please as many people as I can, not going too scientific, but also giving enough information to make it relevant. I hope I can achieve the goal. So what is our agenda? A brief review of anatomy and physiology. Don't panic. I'm not going to go very deep on these things. A definition of depression and anxiety. Is it a symptom or a disorder? Then we're going to be talking about depression and stroke, how to measure post-stroke depression, and lastly, COVID and stroke. So the more things change. In 1977, I started my medical training. Yes, I started when I was 10 years of age, if you're wondering. And so now a blast from the past. In that year, Elvis was found dead when I started my university. Rush was just starting, and my hair looked very much like this guy, although shorter and with less of a mustache. And there was a Trudeau in Ottawa, a separatist in Quebec. The American friends down south are still crazy about their guns. And a movie started in theaters which might or might not have made a big splash, and it's still going on. So this is how we learn anatomy back then in 1977, by Gray's anatomy book, which I still have behind me. In that book, there were very high definition pictures, as you can see, mostly drawings from literally the beginning of the 20th century. And this is how we needed to learn. So we knew very, very little about the brain itself. There were no CT scans and no MRIs. So it was basically clinical acumen that allow us to diagnose and hopefully diagnose accurately. In that year, electronic microscopy also started getting quite a lot of attention. This is a neuron. So this was the first time we could see neurons, cells in 3D. So this is the cell of the neuron. This is a long connecting cable called the axon, synaptic areas, dendrites, like a tree basically. And this is another neuron here. So when we started getting more specific information about the brain, we also started getting more information about what was functioning. Now, if we jump to these days, when we have, among others, 3D SPECT scan, we can, through very sophisticated techniques, see not only what the brain is looking like, but what the brain is doing. So the areas in bright red, and hopefully you can see my cursor here. If you cannot, let me know. The areas in bright red are areas that are consuming a lot of sugar. So if we add a little bit of a tiny radioactive tracer, and we then ask the patient to do a particular task, we can see what's activating and what's not. The redder the areas, the more activity. We can also see the arteries in the brain and the gross anatomy of it. This is not the most sophisticated technique now. We have 3D MRIs and functional MRIs that allow us to see even more. But why is this relevant in this topic? Because through all of these examinations and research, we've been able to ascertain where certain substances in the brain are made. These are called monoaminergic nuclei. Some of you might have heard of serotonin or histamine if you take an antihistamine that blocks this particular neurotransmitter. Dopamine, which in Parkinson's disease goes down. Acetylcholine, which is involved in memory, noradrenaline, in feel good, same as serotonin. So through many, many decades of research, we found out that all of these nuclei, all of these congregations of cells are in the base of the brain. So this is where the happy hormones are produced, so to speak, the movement, smoothing hormones, the anxiety-provoking hormones and neurotransmitters, etc. Now, that's the factory. In order to ship all of these substances to the rest of the brain, there are many, many pontine dorsal cortical relays. This is the pons, and this is the cortex. So that's why it's called the pontine, basal ganglia, like the thalamus, and cortex. So when these substances produce, say, noradrenaline here in the locus ceruleum, those long axons that I showed you before take that particular substance to the rest of the brain. Why is this important? Well, imagine you have a stroke like this one. Now, obviously, this is a massive old stroke in the right middle cerebral artery, opposite to the side of Mr. Stevens' stroke. This is obviously a catastrophic stroke, but you can see how all those areas in the center of the brain that were supposed to be producing the feel-good hormones, the moving neurotransmitters, the memory encoding neurotransmitters have been affected. Hence, the transmission goes down. Now, after a stroke, it's not just neuroanatomy that gets involved. It's not just the architecture of the brain that gets affected, but it's also a chemical reaction. We call those cytokines. And cytokines are substances that are produced everywhere in the body that tend to produce inflammation, tend to produce response, immune response to other agents. So for example, after a stroke, your temperature might go up and edema or swelling of the brain might happen, which are in red, the problematic reactions of the brain. There's heat-related proteins that protect the brain. Now, when it comes to the vasculature or the arteries and veins, they are flooded with neurotoxins because when cells die, substances inside of the cells come out of the cell, and those particular substances are not very good to other areas around the cell. There are adhesion molecules trying to stop the bleed, for example, and the arteries themselves that bring oxygen to the brain might be injured. Now, in the neurons, sometimes there's seizures because there's such an inflammatory response, but there's also protective factors. The brain activates trying to decrease calcium, decrease excitatory substances that make us awake or alert, and increase substances that make us relax, like GABA. And the scaffolding in the brain that sustains the neurons, there are many types of cells in the brain, might be also producing neurotoxins, but also growth factors and neurotrophins that over time try to protect the brain and rewire certain areas. So this is what happens in the very tight balance between neuronal survival and death. So we have the vasculature problem, the neuronal problem, and general actions. Now let's talk about post-stroke mood disorder, if I may. And let's start first with what is a mood disorder? What makes us sad? Well, helplessness, as Mr. Stevens was saying, guilt, shame, loneliness for sure, especially in the past 3 years, pain, constant pain, hopelessness, isolation, and certain hockey teams' lack of championship wins, hockey team that shall remain nameless, because I don't want to be sued. So what about depressive disorders? There are many depressive disorders. There's major depressive disorder, the garden variety depression, disruptive mood dysregulation disorder, persistent depressive disorder, used to be called dysthymia, which is a constant low-grade depression, premenstrual dysphoric disorder, substance or medication-induced disorder, but all of them share in common sadness, guilt, shame, irritability, and in severe cases, suicidality. Now, in the case of stroke, this is what we're going to be dealing with, depressive disorder due to a medical condition, and we would specify stroke. Now, DSM is the Diagnostic and Statistical Manual, basically is the catalog in psychiatry that allows us to communicate worldwide between professionals and define what is an illness. So depressive disorder due to another medical condition is defined as a prominent persistent period of depressed mood. We will deal with it later on, but there is evidence from history, physical examination, or lab findings that the disturbance in mood is a direct consequence of another medical condition. This is not just depression after a loss. This is directly related to the stroke. So what to look for? That's him. That's the one. I'd recognize that silly little hat anywhere, says the lady. I loved Larson and The Far Side. It's a shame he stopped doing it. So what do we look for? In a mood disorder, and this is very important, symptoms must be either new or be noticeably worse compared to baseline prior to that episode. These symptoms have to persist most of the day, nearly every day, and this is important for at least 2 consecutive weeks. The episode must also be accompanied by clinically significant distress, and the most important part of all this slide is the last one, impaired functioning. If we have a loss or a problem or some stressor, but we're still functioning and it causes distress, but not significant, and it does not happen every day, we might have a mood dysregulation issue, but not a disorder per se. So what is a major depressive disorder? I like to divide them in emotional symptoms, which consist of constant sadness almost every day, feeling of worthlessness, of excessive or inappropriate guilt, suicidal thoughts, and this is very important. I'm going to talk later on a little bit about suicide. The myth that if you ask somebody whether they are suicidal or have suicidal thoughts, and that's going to then put the idea in their head, has been debunked by research many, many times. Actually, people feel relieved when somebody asks them, are you feeling hopeless? Are you feeling like life is not worth living? Do you feel that your family might be better off without you? Those are critical questions. And then lastly, do you feel like killing yourself? Also, emotional symptoms like loss of interest or pleasure in favorite activities. What are the physical symptoms? Low energy, psychomotor impairment. We move slow, we think slow. As of late, we're starting to recognize that aches and pains are also part of depression. Insomnia, or its opposite, hypersomnia, sleeping too little or not at all, or sleeping too much. In depression, the typical pattern would be either inability to fall asleep or waking up several times during the night. A change in weight, whether it's losing weight or putting on weight, and low to absent sex drive. What about behavioral symptoms? As I said, change in appetite, impression of restlessness. The person cannot really stay still. They're agitated, or the contrary, a sense of apathy. They don't care. They have no interest in doing things. And cognitive symptoms, difficulty making decisions or focusing, problems with attention, and memory problems. So you can realize how many of the symptoms of depression mimic to a T what the patient with stroke has. And it's important to then tease them out. What is what? A little perspective from Stats Canada. The next slide comes from the 2016 census data, which is the last I had available to. This, of all the slides I'm going to show you, this is the saddest. From 2012 to 2016, there's been on average about 450 homicides in Canada. Each one of them is a tragedy. It's an absolute disgrace, a tragedy. And we hear about them often in the media, whether it's online, social media, or old fogies like me on TV, radio, but we hear about them. Somebody gets killed, it's gonna be on the news. 450 on average every year, which pales in comparison to 10 to 11 times more suicides every year. 4,000 people kill themselves every year in Canada, and we don't hear anything about it. Why? Stigma. Stigma kills. Journalists are hesitant of talking about suicide because they are afraid to, I'm going to put the information in the heads of people and then they're going to start killing themselves. We don't have clear statistics as to what has happened during the pandemic, but this is important. The vast majority of those intentional self-harm suicides are people who were depressed. So let's talk a little bit about anxiety. What makes us anxious? Well, death, illness, money problems, relationships, work, exams, and certain hockey teams' lack of championship wins. Why we even have them beats me. So anxiety, again, disorder. Symptoms must be new or noticeably worse compared to what they were prior to the onset of the problem. They have to persist, again, most of the day, nearly every day for at least several consecutive weeks. And you guessed it, they have to be significant distress or impaired functioning. Otherwise, we don't have a disorder. We might be anxious, but it's not a disorder. This is very important in my practice because I have to tease out what is a normal, reactive, anxious response to a stressor and what is actually a disorder that needs treatment. There are at least 7 anxiety disorders, and I don't have time to go through each and one of them. Generalized anxiety disorders, people who worry all the time, even about the smallest things. Panic attacks, when they happen too close together and in a certain frequency, we create panic disorder. The fear of going out because of a safe environment or being in a wide open space or in a space where people cannot escape rapidly is called agoraphobia. Post-traumatic stress disorder, PTSD, which has been portrayed in media umpteenth times and more often than not is not well diagnosed. Social anxiety disorder, or social phobia, extremely shy people. Simple phobia, which many of us have, the fear of heights or flying or snakes or etc. And obsessive compulsive disorder, people who feel they have to control their environment as much as they can, and they have obsessive thinking, ruminative thinking, producing anxiety, and if they don't do a particular act to ease off the anxiety, they cannot settle down. What is the lifetime prevalence? In other words, how often do they happen? It's huge. In a lifetime of the population through many studies, we know that about 30% of people in their lifetime will have anxiety, more than mood and substance use together. Typically, anxiety disorders are underdiagnosed, undertreated, and grossly underfunded. So now you just worried. Come on, you're a worry word. Yeah, grandma's a worry word. Yeah, don't worry about it. When in fact, the person is suffering. What are the risk factors for anxiety? A family or personal history. I can tell you that in all of my cases of anxiety, there's 1, 2, or 3 family members throughout the generations that have the same. Personal history of mood or anxiety disorders is a huge risk factor. It happens more, I shouldn't say that, there's more prevalence. We detect more in women. It might be a bit of a cultural bias. It might be that women are more in tune with emotional feelings, emotional display, and are more keen of talk about it, while us guys are kind of stupid and have to keep it inside, and we get pissed off and angry and irritable instead of expressing what we're feeling. So it might just be a sampling data. It happens at all ages. From the age of 3, you can already tell more or less who's an anxious kid, all the way to old age. Loneliness, low education, and adverse parenting are risk factors. Chronic, physical, somatic means physical. Somatic illnesses like heart disease, diabetes, asthma, and obesity might increase the risk. Why obesity? Because obesity is a risk factor for cardiovascular disease and diabetes. Substance use and a history of mood disorders. What are the typical features of an anxiety disorder? Well, let's go again to the cognitive symptoms that include persistent thoughts such as something is going to go wrong. This is typical. This worry is going to make me nuts. I need to be sure nothing bad is going to happen. So I feel I need to control my environment. Physical symptoms, muscle tension, typically the neck, low back, jaw, forehead, feeling keyed up or on edge, restless, irritable, and sleep disturbance. And typically is not able to fall asleep or waking up in the middle of the night and they start ruminating on the anxiety. Behavioral symptoms include avoiding anxiety-provoking situations, restricting involvement in activities due to excessive worries. I'm not going to travel on the plane because the plane's going to fall, or I'm terrified of crossing the street, etc. And excessive reassurance seeking or over-preparing, like some presenting guy I know that talks on strokes. Let's talk about post-stroke depression. It's the criteria is extremely similar to regular depression, and you need 4 or of the 9 symptoms with depressed mood that we normally see in depression: weight loss, insomnia, psychomotor agitation, fatigue. This is very common after stroke, even without depression. For some reason, we're not able to understand. People after stroke get extremely tired between 1 and 3. I had one of my fellows try to research why it happens, and there's a myriad of factors we still don't know. And that's the time when our physios and OTs in speech try to engage some of the patients in therapy. So we had to change schedules. Feeling of worthlessness, diminished concentration, suicidal ideation, and again, it has to last 2 or more weeks. What is vascular depression? This is a relatively new concept. I'm going to get a bit technical, so my apologies. This is related to small vessel ischemia. Ischemia means certain tissue run out of oxygen because the vessel that carries the oxygen, the blood, collapsed or is blocked. So this is related not to the big vessels, like perhaps what Mrs. Stevens had, but small microscopic vessels. It affects the white matter, the centers of the brain, all of those axons, all of the cables like this one. So if this is the neuron, this is the axon. And so when microscopic vessels start to get blocked, all of this white matter, all of the axons start to disconnect. It starts late in life, which is not common in regular depression, much greater cognitive and physical impairment, and less family and personal history. So these are people who have no history of depression in their families or themselves, and all of a sudden after a stroke, they get depressed. They respond differently to treatment, and they have different prognosis. Some of these vascular depressions are very hard to treat. Typically, they're associated with executive dysfunction. Again, apologies for the medical lingo. The cognitive dysfunction is higher in vascular depression, and there's poor response to treatment with regular antidepressants, and it has a more chronic and relapsing clinical course. So what does it look like? This is a gentleman or lady who suffered a brain injury earlier in life. So you can see here the scar. This is an MRI on T2 type of MRI. So anything that's white is not normal. And this is probably an old fluid collection, like we saw in the slide I showed you of the sample from stroke. But this tiny white dots are the problem. So this is the small vessel disease, leukorrheosis. This is what causes the cognitive impairment, the depression in post-stroke. So for example, this is a normal MRI of an older patient. And all of us at some point, if we live long enough, we're going to have all of these tiny spots in our white matter. And some are really benign. The vast majority are really benign. The radiologist will tell you they're non-specific, no clinical consequence, as opposed to vascular depression. And you can see the huge lesions here. This is easy to spot. So what is the etiology? What causes post-stroke depression? We really don't know. We know that there's disruption in the production of all the neurotransmitters. We know that there's disruption in how they are transmitted to the rest of the brain. We know that there has to do with inflammation and structural damage, but we still haven't been able to pin down exactly what are the reasons are. So let's move on to best stroke practice recommendation. And I'm going to base all the information on the update from 2019, which is based on this article. In the last edition of the guidelines, recommendations for the treatment of mood and cognition say all people who have experienced a stroke should be considered at risk for post-stroke depression, which can occur at any stage of recovery. So we hate math, say 4 in 10, majority of Americans. I love these clippings from newspapers. You cannot make this thing up. So let's talk a little bit about statistics and epidemiology. 61 prospective studies means we study ahead and see what happens, who gets depressed, who gets mental illness after stroke. 30% of all stroke survivors will experience depressive symptoms at some point. That's a huge number. Now, in a population-based study over 2 years, new onset depression was 3 times greater in stroke compared to a similar large age and sex matched community-based sample. So clearly, depression is a risk factor after stroke. The frequency of depression is higher in the first year following stroke, but can remain for years. Increasing age is a risk factor. Living alone is a risk factor. High levels of comorbidity if the patient also has pain, diabetes, hypertension, headaches, heart disease, asthma, etc. A history of depression. If you were depressed before the stroke, chances are your depression is going to get worse afterwards, unless you're treated. Once again, females. And once again, we don't know if this is just a statistical issue. Physical disability, the higher the ranking scale, the scale of physical disability, the greater the risk of depression, especially if it involves aphasia. If you cannot communicate or cannot understand, the risk of depression and agitation and even aggression goes through the roof. An increased initial stroke severity and cognitive impairment are also risk factors, as expected. If you had a prior history of stroke, if this is a second or third stroke, your risk of depression goes higher too. Literature review, what does the literature say? And again, you cannot make this one up. Mississippi's literacy program shows improvement. Really? But anyway. So what does the literature say? This is a classic article by Robinson and Jorge about stroke depression. In community centers, the percentage of patients with depression, community-based settings, this is major depression, this is minor depression. About 15% of people will get depressed. In acute or rehabilitation hospitals, a much higher percentage, almost double. Why is this? Perhaps because they get diagnosed more. Now, in outpatient populations, it's the opposite. It's even higher because they might not be diagnosed. Over the years, in the studies that have been done about depression after acute stroke, we found out that depression severity was an independent predictor of impairment in activities of daily life. And it makes sense. It's one of those duh kind of scenarios. Of course, if you're depressed, you're not going to function well in meal preparation or having the energy to go out walking or participating in things. But it's more than just the psychological aspect. It's the chemical reaction, the self-destruction, the neurotransmitter that causes this. So treating depression is crucial. And this is very clear in one of the studies by the same authors from 2016. This is percent survival, and this is in treated and untreated at year 1, 5, and 9. So those who had depression, who were treated, were easily surviving. 100% of them survived at the first year, and those untreated, about 85% survived. But if you go by year 5, yes, some people with depression will pass on for some of the reasons, but and will not survive as much. But the people who are depressed definitely die sooner. And by the 9th year, you can see the trend. So it is crucial to treat depression. Now, Mr. Stevens was talking about how he became more tearful. This is what we call emotional discontrol syndromes. So all of us have a quote unquote normal emotional response, most of us, so to speak. So let's go what happens if these type of emotional responses get worse. The first step is emotional lability, which is what Bill had. I hope I can call you Bill. What he had, which is crying at the drop of a hat. You see a cute ad on TV and you well up and you go, what the heck's going on? This has never happened to me before. And by the way, as we age, it can happen, all of us. So the regulation our frontal lobes have on the emotional expression areas in the base of the brain kind of decrease a bit over time. But this is still normal. This is not normal, but it's easily treatable with behavioral strategies. It's easily treatable by informing the patient, like I'm doing now, this is normal. No, you're not going crazy. No, you're not going soft. This is just your brain becoming more sensitive to responses. And the extreme is called pathological crying and laughter syndrome. Unfortunately, I don't have time to show you a video of somebody having pathological laughter. It sounds like a lot of fun when you see the first 30 seconds. This guy laughs and laughs and laughs until you realize that he cannot stop and that he's having a tough time controlling when he's crying and when he's laughing. And this is the population that requires medication to control it, and it works really well. Question: who would win the next presidential election if it were held today? It's a pretty clear question, right? 76% answered yes. 24% answered no. 389 people answered. You have to be very clear in what you ask. And as clear as question as this, even then you scratch your head. So any screening of depression, like the screening we do for stroke, has to be very carefully done. This is the National Institute of Health stroke scale score, where no stroke symptom is 0 and severe stroke is up to 42. Again, 2019 recommendations: all people who have experienced a stroke should be screened for post-stroke depression. There are many scales, and I mean many, if I hadn't said many enough. You can screen for mood by history. You can then screen through using different scales that I'm going to talk about. But the message of this slide is you need to screen, because chances are, based on the statistical information we have, the patient's going to have symptoms. So what can we do? Who can be screened? 70% of patients were eligible in this article in 2014. The 30% that were not was almost always due to a cognitive communication disorder or frank aphasia or another medical condition that didn't allow them, say they were blind or severely deaf. How do we screen? There are many scales: the 20-item CESD, Center for Epidemiological Studies and Depression scale, the 15-item geriatric depression scale, the 21 Hamilton depression rating scale, 9-item PHQ, patient health questionnaire, and the 2-item version of the PHQ. Let me show you what the center, the CESD scale looks like. 20 items, and it screens for all of the symptoms of depression. So being bothered, appetite, the blues, feeling not as good as other people, etc. And you rank from 0 to 3. The problem is that this is a heavy scale to apply in patients with strokes. So the GDRS, geriatric depression ratings scale, is titrated and designed for people in older populations. Good sensitivity and specificity. Sensitivity means it picks up the symptoms. Specificity, it picks up the symptoms of depression, but it's not well tolerated in hospital medical patients. And a short form of the GDRS has not yet been evaluated for stroke, to the best of my knowledge. So this is the GDRS. And again, like the previous one, it's kind of work heavy. Satisfied with your life, yes or no? Drop main activities, yes or no, etc. So in somebody who's fatigued, who's depressed, who has problems paying attention and concentrating, it's hard to apply a 15 or a 20 item scale. The Beck Depression Inventory has been around for 50 years, well validated and reliable, easy to administer. Many of you will know it. Fast screen for medical patient, but it's not validated for stroke, so I didn't show it in the slides. This is a PHQ, the 9-item patient health questionnaire. So in the past 2 weeks, how often have you been bothered by? Little interest, feeling down, falling or staying asleep, tired, having little energy, poor appetite, feeling bad about yourself, trouble concentrating, moving or speaking so slowly, thoughts that you better be off dead or hurting yourself. So very quick screening of all of the symptoms of depression. And then if somebody scores 1 to 4, not depression, 20 to 27, very severe depression, is easy. Like anything in our society these days, we have abbreviated versions. So imagine if we had the abbreviated version of The Wizard of Oz, transported to a surreal landscape. A young girl kills the first person she meets and then teams up with 3 strangers to kill again. That's The Wizard of Oz. But we do have the PHQ, the Patient Health Questionnaire, and basically it's 2 questions. Little interest or pleasure in doing things, feeling down, depressed, or hopeless. You can ask these 2 questions to anyone. Remember, these are not diagnostic scales. The diagnostic scale, the SCID, takes a couple of hours to apply. So this is not for diagnosis. This is a screening test. This is just, we're looking for symptoms. In patients who have communication disorders, the visual analog mood scale is very useful for stroke patients with communication disorders. It's 8 cartoon face from happy to sad, and then the patient points as to how they feel. In patients who have even more problems motorly, now we have visual analog, and it's through an app. So the patient in a computer grabs the mouse and just slides the scale as to whether they feel that way or not. And it's if the patient is satisfied, the face changes to be happy, or miserable, the face becomes sad or angry. The ADRS, a phasic depression rating scale, it's an observational scale. What does this mean? This is a scale that us, the staff dealing with a stroke patient, applies, and it's designed to diagnose, monitor patients with aphasia. So it says, is the patient participating? Is the patient eating? Is the patient sleeping? As an observational scale, is not as good as a scale that the patient can answer themselves, but it's better than nothing. Once again, the guidelines, pharmacotherapy, we're talking about treatment. So people who suffer from mild depressive symptoms can be treated by watchful waiting. No medications are necessary, but we need to watch them carefully. And therein lies the rub, because accessing mental health services in Ontario, and I might even say in the world, because I speak with my colleagues elsewhere, is becoming very challenging. Our waiting lists are obscene, and the amount of beds or appointments is not as high as we would like to. So take this with a big grain of salt. In people diagnosed with a depressive disorder, they should be considered for treatment with an antidepressant medication. And those 2 are level B. The best level is A, level C is the lowest. Not one drug or drug class has been found to be superior. Basically, the SSRIs, and I will name a few in the next slide, are favored because they have very low side effects and well tolerated, and then can be added to the medications that typically a patient with stroke is taking. Personal preference. There's no information that I can quote you that shows one is better than the others, except that the only two we have with some level of evidence is sertraline or citalopram. Now, remember that, like the snail, we have to start low and slow on the doses. So if we start a non-stroke patient on 50 milligrams of sertraline, the lowest dose, I start my patients at 12.5 after a stroke. And I keep them there for a week, and then I increase to 25 for a week. And if tolerated, I increase to now 50. And all of these agents, every single antidepressant available in the market has a lag time before response of 4 to 6 weeks. So you start the medication and you sit and wait until it works. But once it starts working, patients feel remarkably better. And these are well-known, safe medications that have been around 30 years or so. I am more afraid of Advil than of any of this. What happens with the survival rates, 9 years follow-up, as we talked about before? The patients who are treated and receiving antidepressants do better in terms of mortality than the patients who were receiving placebo. What about motor and cognitive recovery after stroke? This is a Cochrane review that's already quite dated, but it's a very difficult thing to study. Now, we know from animal studies from the 2000s, the early 2000s, that when you give a rat a stroke and then you put the rat on an antidepressant, and then the rat dies and you look at the brain, the rats that were taking, and in this case was citalopram had a lot of new connectivity. New cells were formed in the center of the brain, the cradle of the neurons, and emigrated to the cortex through the axons, as opposed to the animals that died after a stroke and had no antidepressant. There's a ton of data, 52 research trials with 4,000 plus that people with SSRIs, and it showed that SSRIs, the antidepressants, might improve recovery after stroke, even in patients who were not depressed. There's a study going on now between, I think it's Germany and the States, in which they were given, patients who have a stroke are given immediately an antidepressant, and they're following, even if they're not depressed, to see what happens instead in motor recovery, cognitive recovery, and not just mood. Two studies are famous. One is a focus study, fluoxetine for motor recovery, called the FLAME study, randomized placebo control, published in 2011, which showed great results. But afterwards, in 2019, the focus study showed that maybe not so much. So we're still uncertain in humans. I can tell you anecdotally, my patients with stroke and depression that are treated with the antidepressant, any antidepressant you want, in the long run do much better. Non-pharmacological management of post-stroke depression involve either cognitive behavioral therapy or interpersonal therapy. What is that? Basically is psychotherapy. So what are the non-pharmacological treatments? Physical activity, key. Cheap, underestimated, underrated, extremely effective, easy to apply. Exercise. Psychotherapy, non-invasive brain stimulation like transcranial magnetic stimulation, I'm not going to talk about, and some studies on acupuncture, but the quality of the studies is not great. The samples are not great. So don't go get acupuncture for treating depression after stroke. We still don't know. Psychotherapy, cognitive behavioral therapy, challenging the negative thoughts, challenging what is going on through your head, challenging the assumptions that you make, teaching the patient to understand that feelings are not necessarily true, that thoughts are just that, and not necessarily representing the future. Behavioral therapy, changing activity basis, maladaptive behaviors, problem solving, which our occupational therapists are fantastic at, and motivational interviewing, which is a little bit of what I'm doing right now. As I mentioned before, exercise for depressive symptoms in stroke, great results. If the patient, not if, the patient will be able to exercise regardless of level of disability to some extent, so we encourage that. Now let's move to the next stage, an uninvited guest. By now we all know what this guy is. It's a virus, and it's called a coronavirus because of all of the spikes form a corona, which means a crown around it. There are 7 varieties of COVID, of coronavirus. This is the most common one, the common cold, the one SARS in 2002, which I lived through and lost one of my classmates and one of my nurses to it. This was basically hospital-based, and the other two were the other one in Holland and Hong Kong, the Middle East MERS, which we had here, and lastly in China, in Wuhan. What are the potential acute symptoms of COVID? I'm not an infectologist, an infectious disease specialist, or an immunologist, but I can tell you that of all of the symptoms we can get, and probably several of the members of the audience have had COVID and recovered well if they were vaccinated. The most risky ones would be heart disease, arrhythmias, inflammation of the heart, or heart attacks. What about potential long-term symptoms? Hair loss worried me. I had no idea. Fatigue, very common. All of the cardiac problems, joint pains, etc. But when it comes to my level of expertise, my area of expertise, we really don't have a lot of information. What are the long COVID risk factors? Obesity, age, asthma. Why obesity and age? Because people have more comorbidities. Asthma, well, it's a respiratory infection. Female sex, we don't know. Being in poor socio-demographic factors, poverty, workplace stress, and poor general health. When it comes to the mental health issues in COVID, as you can see, anxiety, #1 when it comes to mental health, and very high up at 12 months, and depression also very high up compared to chest discomfort, for example, or cough. So cough is 0.6, anxiety 12.9. We were very scared at the beginning of the pandemic that people with strokes were not going to get the same care. And fortunately, in this study from 2021 in the States showed that actually, if the patient is able to get to the hospital fast enough, and therein lies the issue, the care was the same in post and pre-COVID for the most part. What about the long-term effects of COVID on mental health? We were really concerned that there were going to be a lot of people either getting really depressed, really dementing after COVID, or killing themselves after COVID. And fortunately, all the studies that have been done, and this is a year ago, showed that there's the long-term prevalence of anxiety, depression, PTSD, and sleep is comparable to the general population. So we never saw that tsunami we were expecting to see. Again, another story, mild and long-term neurological and psychiatric manifestations at months. Long-term is the transparent dot, mid-term, the dark dot. So at the beginning, the lack of smell, a fair number of patients, but anxiety in the long term, the longer the symptoms go, the more anxious they become. Cognitive dysfunction, the longer it goes, the more cognitive dysfunction we're seeing, and depression and fatigue for sure. What's the impact on of the pandemic on mental health in the general population? Once again, we were really concerned. Change in mental health symptoms varied substantially across studies in the first 2 months of the pandemic. The problem is that there's so many populations being studied, from the young to the old, from the well-off to the poor, from the ones in great health systems to very poor health systems, to where they well nourished, poorly nourished, etc. Level of education. So it's so many variables that it's been hard to ascertain how people are responding to mental health. And this is brand new, November of last year. So Pandemic effect on stroke. This is my personal observations. The toughest one, as the previous two speakers have mentioned, is isolation. Diminished access to home care, resources like the Y and basic needs. Pause in rehabilitation therapies. I had patients who had to delay the therapies for almost 6 months, and 6 months after stroke is terrible. Pause in support groups, reliance on technology and its challenges. If you're good at technology, you did well. If you were in your 80s and never done Zoom, it was very hard to implement. Uncertainty of what's going to happen, not just with you, but with your loved ones. Anger. This is where all of the political stuff came out. Uncertainty and feeling lack of control. Exacerbation of social and economical challenges. So what are the resources? This is, I hope you can see, the scopehub.ca is a patient resource guide for mental health support. If you want to take a picture of the screen, go ahead. We're almost done. I'll go back if you want to take a picture. Another one is ementalhealth.ca, mental health services in the community. You have the website down there. This is actually pretty good. ementalhealth.ca and thehealthline.ca. And this is regional. And again, we are impoverished when it comes to mental health resources in Canada and probably the world. So it's hard to get help from mental health. I can tell you that in Ontario, if I really exaggerate, and as far as I know, there might be in all of the province, maybe between 20 and 30 neuropsychiatrists like myself for 5 million people. In Canada, we might be maybe 150. There's more psychiatrists, but still there's not enough. So the summary, you survived the presentation. Post-stroke depression is very common. The etiology is multifactorial and complex. It is associated with high levels of morbidity and mortality. If you have a stroke and depression, you're going to be sicker and your risk of dying is higher. Functional recovery is affected in post-stroke depression patients. All patients with symptoms of depression need to be screened. Preventing post-stroke depression has proven challenging since the pandemic. Antidepressants are the first choice with the SSRIs I mentioned, in combination with cognitive behavioral therapy, interpersonal therapy, and exercise. COVID-19 is associated with mental health problems. That's one of the Snyderman issues. And long-term effects unknown. And I'm getting here. Is your drama going to have an intermission soon? I need to pee. So the finale. For the past 5 years, I have ended my presentation with this video. And I thought my audience deserved a full oomph for the finale. However, 2 years ago, I decided I need to shake it a bit. So I searched and I borrowed ideas and pondered for a long time. And at the beginning of this year, I gave up. So with apologies to Tim Minchin, here are my famous final video.
Das hier ist mein Sektor. Das hier ist das wichtigste Gerät des Küstenwächters. Das Gerät und das Gerät. Überlebensradar.
Mayday, Mayday. Hello, can you hear us? Can you hear us? Can you... Over. We are sinking. We are sinking.
Hello? This is the German Coast Guard.
We are sinking. We're sinking.
What are you thinking about?
Das hier ist...
So I try to improve my English and present that way. Now, please, do this presenter a favor. All of us presenters live and die by your evaluations. We get information as to how we do and what topics are of interest. Get your cell phones ready and take a picture of this QR code, which will take you straight to an evaluation you can do very quickly. It's a short one, it's easy, it comes straight to me, And then I know whether you enjoyed it, hated it, and what topics might be of interest. And thank you for your kind attention.
Thank you, Dr. Snaderman. Really appreciate all of the time and effort you've taken in sharing your slides with us and informing us as an audience. At this time, I'd like to invite Bill back on the screen, and we are offering an opportunity for questions and answers to both Bill and Dr. Snaderman. And I believe, Jessica, you've been monitoring the Q&A. Are you able to share some of the questions that have come up for our presenters?
Absolutely. Hi, everyone. I'm Jessica. Thank you, Dr. Snaderman and Bill, for your presentations. They were excellent. I do have 4 questions here as of right now. So why don't we start with the first one? Can everyone hear me okay? Maybe a quick thumbs up. Excellent. So the first question is directed for Bill. Bill, thank you for sharing your story. You mentioned accessing the YMCA program to support your physical recovery after the outpatient service. Did you access any other programs in the community to help you with your ongoing recovery? When you were in the community, I think there are a couple parts to this, just 2 parts. Okay, when you were in the community, did you wish other programs were available? And if so, what types? Thanks again, and thanks for sharing your journey.
First of all, I did not access any other programs. I was fortunate in that the Y program was just starting as I was finishing my formal recovery program. So it almost seemed seamless moving from formal recovery programs to the Y programs. I didn't know what other programs might have been available, and I didn't research as to how to find out about them. So I guess I was satisfied with my transition to the Y programs from the formal programs, and I did not see the need to pursue anything further.
Bill, just in thinking that through, can you share with what you were looking for? So for example, was it physical needs? Was it a social aspect? What were your goals that you were feeling the Y was delivering for you?
The goal really was physical recovery to the extent that I could, but I found through the program that was offered by the Y that the social contact was very important to me as well. So it presented a balance to me that I hadn't anticipated.
Excellent. I will probably move on to the next question then, if we're all set there. So, question number 2 is for Dr. Snaderman. Thank you for your informative talk. If you could redesign the system to prioritize. Sorry, there's a overhead announcement. Thank you for that. Sorry about that. Dr. Snaderman, thank you for your informative talk. If you could redesign the system to prioritize identifying and addressing depression and anxiety post-stroke, starting in acute care, inpatient rehabilitation, community rehabilitation, and beyond, what would the system look like? How can we advocate for these system-level changes as a stroke system?
First of all, before answering this, I'd like to thank Mr. Stevens for allowing me to call him Bill. and not being overly social, since I've never had the pleasure of meeting him. So thank you, Mr. Stevens. Good, thank you. If I were to redesign the system, I would be a politician and I'd rather die. So the way I've implemented this is what we're doing here at Toronto Rehabilitation Institute. And this is the part where I get braggy. I started here in 1995 and there was no psychiatric coverage. So we were missing a lot of cases of depression that I would then catch when the patient was discharged from the e-patient unit to the day hospital, to the outpatient component. So we started adding scales that are social workers, OTs, mostly social workers and OT, in their initial assessment will ask the patient about like the stroke in depression inventory city or the PHQ-2. And we started catching up cases early. Now, when a patient comes to our unit, to the neuro rehab unit, almost all of them will be confused. Am I speaking too fast? Okay, almost all of them will be confused. Almost all of them will be sad, anxious, not sleeping, maybe in pain. So if you were to screen once, almost all of them will have some features of depression. So the idea is you screen at the onset, and a week or two later, once the patient has gotten used to the environment of the ward and they start the therapies, the assessments are done, we screen again. In particular, our social workers and OTs are really good at picking up cognitive signs of depression, and our physios are really good, and speech are really good at picking up issues of participation, irritability, especially the physios. If the patient's in a bad mood, the poor physios get it all. They get the yelling and all that stuff. So then a consult comes to me or to the psychologist. So those would be the changes I would implement. I would have more staff, more money for nurses, more money for ancillary staff, train the staff on how to recognize depression and anxiety as symptoms and disorders, have access to mental health care resources, and follow through the patient. And then you catch the patients that got depressed at what month, at 2 months, at 6 months, at 9 months. If by the 9th month the patient hasn't gotten depressed, chances are they won't. Although I've had patients that even 3 years post-stroke, depending on life circumstances, can still get depressed. But with treatment, it's easier to deal with. I would want to decrease stigma. If I was Minister of Health, touch wood, I would be focusing, and this is selfish, I would be focusing on mental health big time, because what you hear in the media is nothing compared to what we're experiencing here, and worse since the pandemic. It is a huge crisis in mental health. It's not an exaggeration. Just try to go to the emergency department in a mental health crisis, see how long you wait, and whether there's going to be somebody seeing you, depending on where in the province you are. Especially north of Highway 7, the resources just drop dramatically. That's how bad it is. I'm not talking Nipissing or the Cap. The other thing that I would do is expand telemedicine. And that's perhaps the only good thing about this whole COVID nightmare. We have been talking for years about telemedicine. I was one of the first psychiatrists involved in the pilot project for the Ontario Telemedicine Network, OTN, about 10 to 12 years ago. And it opened up. We thought it wasn't going to be well received. The patient had to go to a family practice unit in Thunder Bay or Kapuskasing or Moosonee or whatever, and then connect to me, and I would have to be at the studio upstairs. nowadays with this, it's easy, especially in my specialty, I don't need to touch patients. I can do my work through video. So if there's one advantage is this particular issue. Unfortunately, they are defunding it very quietly, and gradually they're defunding it. So we don't know what's going to happen. That was a long, long answer. And I'm so sorry to the person that's typing my stuff, but.
Thank you. We have 1, 2, 3 more questions, and all for Dr. Snaderman. So Dr. Snaderman, the first question is, can you suggest any strategies or knowledge that the interprofessional team, being PT, OT, SLP, nursing, etc., can acquire to better support persons with stroke with mental health challenges post-stroke?
Very relevant question. And I can say the most, okay, don't exaggerate, Snyderman. The 2 most important issues are, number 1, knowledge. Number 2, empathy. If you have ancillary health, interprofessional teams, and I am spoiled rotten here. We have the teams that are specialized in stroke, and it's not an exaggeration. I couldn't do my job without them, including my pharmacists, including the nurses, including the unit aides. Everybody pitches in. We've educated them in what is depression, what is the symptom, what is the illness, how does it present if you're an OT, how does it present in terms of cognition, ability, participation. If you're a speech pathologist, what about language production? If you're a physio, what about movement speed? Social workers are typically really well informed, so they usually are the ones that pick up this before I do. But that would be number 1, knowledge. Knowledge is power in my world. Number 2, empathy. It is very easy to get impatient at a stroke patient with expressive and receptive aphasia that doesn't understand a word. It's like being dropped in the middle of Beijing, not speaking Cantonese or Mandarin. And it's normal for them to get irritated. So be empathic, be patient, understand, put yourself in the shoes of the other person. That's empathy. Sympathy is, I'm sorry your mom died. That's why it's called sympathy cards. Empathy is, my mom died. I know what you're going through. So yes, I don't have to have a stroke in order to understand what the patient is going through, but I can empathize with how difficult it is for them to live through this. So empathy and knowledge would be the strategies.
Thank you very much. The next question, we still now have 3. Another one came in while we were chatting, so we'll try to get through them. If not, I may defer one to the later Q&A. Next question here is, thank you for your excellent presentation. For Dr. Snaderman, how important do you believe it is for stroke survivors to connect with other survivors in the community to assist in alleviating depression?
Huge, huge. We had a project. As time goes by, everything is 10 years ago. But we had a project about 10, 15 years ago in which we started a survivors group and a group for spouses or caregivers or family members of survivors. It was very difficult to implement because of A, transportation, B, energy, B, attention, concentration, and participation. And also patients were telling us, I don't want to go and hear somebody else complain about their problems when I have mine. That was solved by having people like Bill, who are lived experience people who have gone through this, who are way past the acute stage, who can then coach and explain and guide a new stroke patient into what they can expect and how can they be helped. Then there's the social aspect in their circle, which is crucial. I call it early arrivals, late departures, and it happens also in our brain injury units here. At the beginning, everybody rallies. The third cousin twice removed comes to visit the patient. They haven't talked in 10 years, but they come to visit the patient. Everybody rallies and brings food and is attentive. And by the 6th month, almost everybody has disappeared. So they arrived early, and then as it goes on, people disappear. And that's when the patients find the most challenging, and the caregivers. Let's not forget, as I always say in my presentations, it is one brain, but 10 people affected. So let's not forget about that. Social contact is crucial, and it's hard in patients with aphasia. So there's the Aphasia Institute, and I think they still have online access. I'm pretty sure they still have, in which patients with aphasia can learn to communicate with other people with aphasia, and it's directed by speech pathology. It's a fantastic place. There's the Y that Bill was talking about. There are hospitals with advisory groups that might be able to offer and help. And I'm hesitating because I know there are people in the audience from everywhere in the province, and I don't want to mislead, so I don't know what's in your community. But the most important thing is don't abandon them. If you have a teenager that wants to volunteer because they need X number of hours, great opportunity to visit somebody with a stroke. Great opportunity. If you have somebody who is retired and wants to volunteer, great opportunity. Drive the person with a stroke to an appointment. Meals on Wheels, etc. So crucial. It is perhaps my biggest challenge, trying to treat somebody with depression that is socially isolated. Very hard.
Okay, the next question here. Hi, is there benefit of mood enhancing or antidepressant meds for patient with acute stroke, especially young patients?
Interesting question. And the research is not conclusive. And the reason why I'm hedging a bit is depends on the type of stroke. And this is something I didn't want to get into because it's too technical. We know that people with strokes are more prone to get depressed depending on where the stroke is. Now, this is where researchers start fighting it off. Some researchers say that left-sided strokes are more associated with depression, and left-sided strokes more closer to the forehead, so what we call frontal pole, are more associated with depressions. Others say no, it's at the beginning, it's left, but then if you follow them longer, you realize that the right-sided strokes end up getting depressed. And then there's others that say it's more common in the young. No, it's more common in the old. Typically, my youngest patients have strokes because of bleeds. My youngest is 16. And typically they were born with an arteriovenous malformation or an aneurysm or were spontaneous. And the bleed causes a much more severe type of stroke regardless of the age. So I am very aggressive treating young patients that have sustained a stroke where we have data to support features of anxiety and depression. I rather start the antidepressant early because it takes 4 to 6 weeks to start working. And then if we see that the patient got better even before the antidepressant starts working, we can discontinue it rather than have a severely depressed 25-year-old who has to drop out of university or cannot work and maintain the child and start trying to catch up with them. So in that respect, I'm very aggressive in treating post-stroke depression, as in my opinion, everybody should be. And my colleagues are the same.
Thank you.
Thank you
Thank you,
very much.
Dr. Snyderman. Thanks, Jessica, for facilitating those questions. I think for the sake of time, what we're going to do, I know there's still another question in the Q&A, Dr. Snyderman, that I think we'll bring back to our later Q&A. It's a little bit more involved and would take a bit of time. So let's give it the justice a little bit later on of time. And I'd like to thank...
Once you start me talking, you can shut me up. So you better say, Snyderman, shut up.
Well, maybe what we'll do instead is we'll take a break now. I'd like to invite everybody just to take a 10-minute break, and looking at the time, if we come back for 2:08, then Tammy Tebbett will be facilitating the next portion of our event, and we'll be moving into our panel presentation and another Q&A opportunity. My sincere thanks again to you, Dr. Snyderman, and to Bill for a wonderful first start in getting us launched today. So thank you, and we'll see you in 10.
My pleasure. Thank you.